What's going on, everybody? It's Travis Kelsey. Just wanted to give a big shout out to all the athletic trainers out there, all the prehab, all the rehab. I know I'm not the same athlete without you guys and all the knowledge you guys give me. I'm so thankful to have athletic trainers like we do in Kansas City to prolong my career and keep me healthy during the season. Make sure you have a great VNATA and go Chiefs, baby.
Hi, everyone. Tracy Wolfson with CBS Sports. I wanted to say thank you so much to all of the certified athletic trainers out there for helping to keep our players healthy and safe so that they can play the game that they love, the game that we love. And thank you so much for making our game of football so great. Enjoy the VNATA.
Hello, everyone. I'm Katie Walsh-Flanagan, and I'm the District 3 Director of the NATA. I cannot tell you how happy we are that you made time out of your busy schedule to join us at virtual convention. Thank you so much for that, and please know we miss you. We cannot wait to see you next year in Orlando. Have fun this week.
Welcome, everyone. In order to earn your CEUs, you must watch this session in its entirety, and then take the assessment by clicking the assessment button above the session window. During the live VNATA event, presenters will be standing by in the chat box to answer your questions. You can also use this feature to chat with other attendees. During the on-demand portion of VNATA, the chat feature will not be available. Thank you for being here at VNATA. Enjoy the session.
All right, welcome everybody to our talk called The Clinical Guidelines to Immediate Care and Management of Joint Dislocations. My name is Scott Doberstein, and I'm sitting next to Dr. Scott Kuzma, and we will be your presenters for this session. So we always have to start with a conflict of interest statement, and of course, neither of us have any conflict of interest association with that, financial or otherwise, related to this talk. So we have lots of things that we're going to try and cover today. The first half of which is probably more geared toward going over the position statement itself. That was published in 2018. And the second half is to try and give you more take-home pearls, those kinds of things that are going to help you develop a document or revise a current document that you have. So we're going to spend a little bit less time, hopefully, on the front end of it and more on the back end where you can have the take-home types of messages. But certainly there will be plenty of information for you as you try and develop your own protocol. So we thought we would start with an article that was just published in 2020 in Sports Health by Mixner and Loader. And they looked at the demographic data of electronic injury surveillance over 65 emergency departments in 18 sports between the years of 2005 and 2013. It's quite interesting that they did this with fractures as well. Obviously, we're not focusing on the fracture component, but they looked at 18 common sports and recreational activities. So they're looking at football, basketball, baseball, softball, hockey. They also looked at snow skiing, snowboarding, inline skating, and some other recreational activities. So they documented or found electronic documentation of all of these kinds of dislocations that occurred over those years. And of all of those visits to the ED, 3.6 of those happen to be for dislocations. That gives us an incidence rate of 0.27 per 1,000 people. They also found that the most commonly injured or dislocated joint was a glenohumeral, and it's not on the slide, but that was actually 38.7% of the dislocations were to the glenohumeral joint. Basketball was the most common sport, obviously, at 25.7. And they also did some odds ratio data, looking at who was more likely to suffer these dislocations. It's no surprise to any of us watching this right now that the highest odds ratio demographic for age was 20 to 24-year-olds. Gymnastics had the highest dislocation odds ratio, and males over females. So some real key data laid on, that happened, kind of fueling where we're at and where we're going with this injury management of joint dislocations. So in terms of where we're headed and what's going on, it's all about how we manage these dislocations on the field. Do we automatically ship them? Do we automatically reduce them? Or is there common ground in between where some we will, some we won't? And so obviously that begins with the evaluation of the injury and then how we're going to manage it immediately. Now, the position statement is revolving around this on-site reduction, OSR, that we're going to call throughout these slides. But not all joints and not all injuries are warranted for an on-site reduction. There are going to be times when we cannot, should not, will not perform an on-site reduction, and therefore they need to be transported appropriately for further medical attention. So what that led to is us trying to come up with a position statement. And in 2018, I'd like to thank my co-authors and our chair, Dr. Susan Razi, for all their time and effort in making sure that we got this thing out and got it right. But what people don't understand and what they need to realize is that there's lots of information in here that are going to help us move forward in terms of how we think about managing these problems, whether it's in a minor, whether it's in an adult, whether it's in a senior, and those kinds of things. So a lot of time and preparation went into this. I'll discuss a little bit more about it at the end of this segment. But this position statement is your starting place. It's where we should start all of our ideas and revisions on any current documents that we have. And we're going to use this as groundwork. I'm going to call it a roadmap in a little bit to help us prepare these documents so that they're good for us, they're good for our patients. So now Dr. Kuzma will start with some advantages of this process.
Obviously, anytime we are looking at reducing a joint, there are definite advantages to it. One of the earliest advantages is if you're able to get to a joint right after it is dislocated, that you are able to hopefully reduce it much easier because you can avoid the onset of muscle spasm, swelling, and other problems that would limit your ability to reduce it. When a joint is dislocated and it's not in its normal position, your body's going to try and splint that by muscle spasm. And if you're able to get to it early enough, you can really avoid the difficulty and make a reduction much easier. And then if you're able to reduce it early, that really helps reduce the pain and the discomfort that the patient or the athlete is experiencing, both immediately and help prevent them from, if you're in a more remote location, reducing the time before they're able to get to a medical facility where the reduction is able to take place. So both avoiding some of the muscle spasm and then reducing the pain for the patients is definitely a key factor in reducing dislocations early on the field. In addition, dislocations may compromise the vascular flow, compress arteries and the veins. Reducing it may help restore flow to the limb and then prevent the complications from that. The less time the joint is out of place, the less damage there is to the articular cartilage, the less pressure, and then help prevent further injury and damage to that. Dislocations obviously cause a deformation of the joint and put a lot of pressure on the skin surrounding the joint. So if you're able to reduce it on site, you help decrease the risk of any skin necrosis, open wounds, and things like that may cause problems down the road. In addition, you may take an injury that is emergent and needs to be taken to the emergency room or a medical facility very quickly. And if you're able to reduce it on site, it may make it less urgent and allow you to do it in a more controlled fashion. With high school, you may not need to get an ambulance. You could have the parents take them or similar situations. Obviously, there's always disadvantages on the other side of any situation. With dislocations, there's always the potential that there's a fracture associated with it. Deformities may be from the fracture or the dislocation, and if you perform a reduction on a dislocation with a fracture, it may make the injury worse or cause other problems. Again, the deformity from the joint dislocation may not just be from a dislocation, but may be from a fracture and put it at risk of other injuries. In addition, sometimes without sedation or other medication that a medical facility can provide, it may be very painful or difficult to do a reduction on the field with a patient, and that may necessitate you getting them to a medical facility more quickly.
Well, for those of you who don't teach or don't deal with students that much, you may not realize that there's a new entry-level skill that's been put out by Katie in their 2020 standards for accreditation of programs. And in Standard 70, we've always had Standard 70 about taking care of acute injuries, triaging, trying to figure out life-threatening, in this case maybe limb-threatening. We've been obviously in the recent past, we've been dealing with rectal thermometry as it relates to heat illness. We can start using supplemental oxygen or nebulizers, pulse oximetry in terms of respiratory compromise type stuff. But what they've added is that we should be teaching our students about dislocation and or possible reduction on the field, and or what that looks like in the hospital setting or the clinical setting. So we have this parallel or correlating factor where we have the BOC, the NATA saying that these are our skill sets that we should be understanding, and now we've incorporated them into the students' lives in terms of trying to teach them. One of the issues we obviously have is we're going to teach them all this stuff didactically in the classroom. We'll talk about it in clinic, but let's face it, not every student is going to see a dislocation all the time, multiple ones over the course of their student career. So they're going to have to be taught and trained as well once they become BOC certified as it relates to injury management and this new skill that they've learned about but probably haven't been able to practice it very well. So that leads us to the position statement. And so what we need to realize is I'm going to just outline this as the position statement we need to think of as a general roadmap. It's a way to get from point A to point B. We're just not going to be able to give you all of the detours, all of the turns right and left on how to get to point B. So it's a general roadmap. It's a general guideline, right? It's not steadfast rules. It's not laws. You're not limited to what is just in the position statement, and you're not forced to do anything that is in the position statement. It is a list of recommendations, all right? Now, what people don't realize when they read that or where they see it, they see, well, geez, we're missing some joints. We're only talking about those dislocations common to ATs, and those obviously involve the appendicular skeleton. We don't have anything in there on the axial skeleton. We don't cover every joint of the appendicular skeleton. That doesn't mean you can't address it in your protocol. It doesn't mean you can't go beyond what the position statement says. If you follow the recommendations outside of that specific joint and your doctor, supervising physician allows you to do it and teaches you, you're fine. So it's not a restrictive thing, but it's certainly a general roadmap of what this would look like moving forward. So based on that being a common, and then we had to look at the research, all right? There are lots of joints where we don't have significant amount of research at all. And so we had to be really careful about what we could put in there that we couldn't document about. So I would envision in the coming years, just like a lot of position statements, it's going to be updated. It's going to be advanced. We're going to find more research. We're going to find more data. And we're going to be able to really bolster that position statement moving forward. But this is our starting point, as it were. So if you've read that or you haven't read it yet, but when you look through it, you'll find that there are 5 major categories for these recommendation areas that we talk about in the position statement. Again, we're going to cover some of these, not all of these. We're going to cover them, some of them more in depth, others less in depth. But we want to give you kind of that roadmap, that general roadmap of what these areas are about. And then the second half, we can get into more specifics on how you're going to write your protocol or how you're going to revise your protocol moving forward based on hearing this talk, hearing other talks, and certainly reading the position statement itself.
So some of the legal considerations you want to take into account when you're developing or revising your position statement. And you should do this in concert with your supervising physician, is that you want to check all of your pertinent state statutes, rules, regulations, and things like that. You always want to take into account the local rules and regulations over any national credentialing. So whether you're looking at a state rule or if there's any more local ones, you need to look at those and really focus on those rules to help develop your statement. You should also, once you review all of the state rules, you should then look at your employer-specific documents. Make sure that the protocol that you're developing complies with the dictates of the workplace, whether it's the job description or other things within the role for each employee, that what their employer dictates that they can and cannot do. And then it's always important and a good idea to consult with your legal department, both from your employer's legal department, the supervising physician's legal department, to make sure that everyone is on board and agrees that the position or the documentation meets all criteria. When you've reviewed all of those from a state statute, rules, or regulations and the employer policies, and if those do not restrict an athletic trainer from attempting a reduction, then the order should be provided by the supervising physician, and that should either be an orthopedic surgeon or another sports medicine physician or a general practitioner that's supervising your athletic training individuals or staff. You specifically want to indicate the circumstances when an athletic trainer should attempt an on-site reduction, or the circumstances when they really shouldn't attempt that. Which joints you want the athletic trainer to reduce, and then what technique for each of those joints, and it may be more than one technique, but what technique is recommended to use those in those situations. In addition, prior to kind of developing this, you want to make sure that you have patient consent, or in the case of minors, parental consent with patient assent. And you should always obtain that prior to any attempted on-site reduction of a dislocation. Ideally, this is done prior to the start of a school or sports season. And you want to look at that with the preseason paperwork, both the assumption of risk paperwork, any HIPAA paperwork, or things like that. And then each athletic trainer or athletic training department, you want to consult with your supervising physician to, as we discussed, look at the specific criteria to determine which joints should be performed on site, which joints should be sent to a medical facility, and then what techniques and criteria you want to use to determine that and choose which technique to use. Your supervising physician should then also spend time working with the athletic trainers and the athletic training staff on the specific reduction techniques to use, and then determine, based on the skill and the experience of the athletic trainer, what techniques they can use, when they can then attempt an on-site reduction of a joint, and use a lot of your personal interactions and personal experience with each other to help determine that. The physician should then also limit the delegation of dislocated joints and the reduction of those to the athletic trainers that have verifiable education, that have the training in the specific joints and the specific reduction techniques, and then can demonstrate experience and competency in each procedure and technique that you prescribe in your statement. So based on the position statement, once you have verified with your team physician the competency and the training, under the direction of your team physician, an athletic trainer can attempt reduction of multiple joints. Some of the specific joints that you can attempt are the anterior glenohumeral joint dislocation. We don't really recommend posterior glenohumeral joint dislocations or inferior glenohumeral joint dislocations being attempted on site due to the difficulty with reducing those and typically needing sedation. Reduction of the femoral acetabular joint can be done. This is often a very highly traumatic injury, so reducing it early can really help a lot with pain and prevent further issues, particularly damage to the articular surface. But it can be very difficult. So it's one that if you're not able to reduce and you don't have help, it's better to just send it off, but it can be done under the direction of your physician. Tibiofemoral joint dislocations are typically recommended to be reduced on site due to the high risk of neurovascular compromise. Many times these spontaneously reduce, so you may get out to the athlete and their leg looks normal. But if you lift up their leg and they are grossly unstable, you have to have a high level of suspicion for a spontaneously reduced tibiofemoral joint dislocation, and then appropriately stabilize them. But if you do get to them and it is obviously dislocated, quickly reducing it is very important. Obviously, if you're having any difficulty, again, splint it in place and send it. Patellofemoral joint dislocations are very common and one that is typically recommended to be able to be performed on site, as are metacarpal phalangeal and interphalangeal joint dislocations of the fingers and toes. These are ones that are often very common in basketball and football and other contact sports, and ones that can be easily reduced and stabilized and then may not need urgent transport to a medical facility. On the contrary, there are a few joints that we really don't recommend on-site reduction of. Those include the humeral ulnar joint, the proximal radial ulnar joint, and then the talocrural or subtalar joints. The talocrural and subtalar joints aren't a part of the position statement particularly because there's not a lot of supporting data on this, and there's not a lot of literature on them, and they're not that commonly seen by athletic trainers. That being said, if with your supervising physician feel like reduction of these is reasonable, then that can be developed into the policies and protocols at your individual facility. The main reason we really don't recommend reduction of these joints is typically they are associated with fractures. So the dislocation may not be in isolation, and trying to reduce through a fracture may cause further injury, and these are typically best performed with sedation or after imaging has been obtained to really delineate the full extent of the injury. There are exceptions to this, though. For example, if you're in a more rural site, an emergent transport to a medical facility is going to be delayed, and in your protocol per the supervising physician, on-site reduction may be attempted, then it's okay to do these. But you really want to be cautious and make sure there's no signs or symptoms of fracture. But if there are signs of neurovascular compromise, doing a reduction of one of these joints may help save a limb, particularly if you're far away from a medical facility. If there's any concern, though, just splinting them in position and getting them to a medical facility as soon as possible is good. No one's ever going to fault someone for escalating the level of care to a medical facility. You really only be faulted if something is done that really shouldn't be done, such as trying to reduce a joint that isn't in the policies and protocols, that isn't approved by a supervising physician, unless there's one of these other extenuating circumstances. But if you do attempt a reduction of one of these joints, you really shouldn't do it multiple times. If you can't get it in place easily, just get it splinted and get it to a medical facility and escalate the level of care so that they can be appropriately managed.
Well, another large part of the position statement revolves around these general patient management considerations. What should we be doing with all patients, regardless of which joint is dislocated, regardless of who the patient is, just to make sure we are dealing with what we know we're dealing with. So it obviously begins with a history. And at this point, we want to triage and make sure that the dislocation is the primary injury. We don't have any other things going on that might take precedence. So we're triaging that. So if they had a loss of consciousness, if they had a head injury, if they had a neck injury, those might take precedent over reducing this joint at that time, or at least trying to rule those out and figure out where they're at with that. But let's, for the sake of assumption, just say that it is a classic dislocation. There are no other major issues going on. This is the primary injury, so we want to know about paresthesia and numbness. We want to find out from the patient, have you ever injured this joint before? Is this a recurring theme? Has this been a bad joint your whole life? Have you had surgeries to this joint? Those kinds of things. And so we want to get a feel, because again, we may not know this athlete, but if we know him well, we may know some of these answers, right? And then is there any medical condition that we need to know about that may affect our ability to help them through this process? The one that comes to mind, we'll talk about maybe a little bit in special populations, is a diabetic athlete. There might be some contraindications there. So get a good history before proceeding. However, the biggest thing that we need to worry about and understand is the neurovascular status of our patient, all right? That has to be done first. So we've taken the history, we understand what we think is going on, we're trying to figure out if this is a fracture, dislocation, both, or just one or the other. And one of the ways we can help our patients is to understand that neurovascular status going in sensory motor and blood flow. And so when we figure out what that neurovascular status is, we just want to remember that we're going to document it when we're all done. Just like we're going to document what happened, we have to remember to document that neurovascular status that we had prior to any reduction attempt. Now, if we have a possible fracture, a probable fracture, certainly if it's an open fracture / dislocation, we're not going to be reducing it whatsoever. So this would be part of our protocol to put in there on the do's and the don'ts related to neurovascular compromise. So this next slide is really about what's going on after. So we've either reduced the joint or we have attempted to reduce it. And it didn't go in easy, and we're not going to try a repeat attempt per our protocol probably, unless it's specific to a certain joint. And so we're going to check that neurovascular compromise again. If you didn't get it reduced and you're not going to be able to attempt it anymore, and your neurovascular status is getting worse, your exam is becoming more positive, that makes it more emergent. If you reduce it and the neurovascular compromise doesn't exist anymore, the colors come back, it's not cold, it's pinking up, then you have done a really good job of saving that joint. But again, regardless of if you got it reduced or you didn't, you have to document what happened to the neurovascular compromise or status after that. Regardless of whether you were successful with your reduction attempt or were unsuccessful on an attempt, we are still going to immobilize and we are going to treat for pain and spasm. We're going to try and keep these patients as comfortable as possible, whether we were successful or not. And 99.9% of the time, probably should be 100%, they need to be referred for further evaluation and treatment, i.e. an x-ray to see if we have good congruity, if we have a fracture we didn't know about, to check certain other things on that x-ray. But if we reduced it, it may not, like Dr. Kuzma said, it may not be emergent. It could be something that could wait till halftime or after the game and the parents could take them and so on. This is Dr. Kuzma, sorry.
So some general patient management considerations you should take into account when you're developing your protocols and developing your written statements is if the patient is at an age where they may still have open physes, you really should not attempt on-site reduction. The reason for this is that typically in the younger patients, and this may be more elementary to some middle school patients, the presence of a fracture is much more likely a lot of times than a dislocation. So in those patients, you should really just splint them in position and send them to a medical facility so you can obtain x-rays prior to any attempted reduction. If there is a physeal injury or a intra-articular injury and a reduction is attempted, it could always make it worse and go from needing just a reduction under sedation to needing surgery. So getting them to a medical facility is very important. In addition, they do show that if working with your supervising physician, if they approve it, athletic trainers can perform on-site reduction of patellar dislocations in children. But however, as we talked about, other joint dislocations in children should really be reduced only after x-rays are obtained because of the open physes, and there's a much higher likelihood of fracture causing the deformity as opposed to just truly a dislocation. For some of these other special populations, such as senior athletes, diabetic athletes, or dislocations that occur from a seizure, particularly tonic-clonic seizures, we really would refer you to the position statement for special considerations in developing your policies in regards to those populations.
So what it comes down to for every single one of us watching this, if we're an AT, is that it's going to be our responsibility with our employer, with our institution, to try and develop some kind of protocol, guidelines, or policies. Now that we have a position statement out there, it doesn't mean you have to do any on-site reductions, but you probably should have a policy stating that you don't do it, that you don't want to do it, that you will not do it. But of course, if you're going to do any joints whatsoever, you're going to have a policy and a protocol to do that. And so the development of this management protocol takes some time. It takes a lot of effort. We'll talk about some things and potential challenges, but it needs to be done in a timely manner so that everyone can benefit from it. Now, what has to be understood, especially if you read the position statement, you understand that we need to make sure that our policy and protocol is relevant to us and what we're dealing with, our specific population, whether they're minors or adults, whether we're working for a university or a clinic or a hospital system. I mean, we cannot put out a standard protocol that everyone can follow. It's just not possible. And then I think a key part of this, because I did mine years ago as a head athletic trainer prior to the position statement being in, it needs to be modified as necessary. It needs to be a fluid document. It needs to have the adjustments made to it, I would say annually. We reviewed ours annually to make sure that we're up with what the current research, in this case, the position statement I mentioned earlier. I wouldn't be surprised if in a few years we redo the position statement based on more clear evidence that has been studied since we wrote the last one. So you're also going to have staff changes. You're going to have maybe a different supervising MD who comes in. You might take on a new specific population that you hadn't before. Maybe your license changes. Maybe BOC adds something into the skill level, entry level, and so now we're teaching it in younger, and our veterans have to come aboard. So every year, once you've developed this, it should be revisited to make sure that we're doing the right things and we're staying up with the times, just like anything else. So that concludes basically kind of covering some of the key parts of the position statement itself. And now we'd like to figure out how to help you develop these protocols and these guidelines in a much more specific way. So if we're using the roadmap as a specific, okay, we are going to have many obstacles. We're going to have roadblocks. We're going to have traffic jams. We're going to have detours. When you think you're going down this path and you want to get to point B and you realize, I can't go that way. I have to do something else. And so some of those things that may influence your ability to develop this protocol would have to do with how are we going to discuss the possibility of a fracture? Are we going to say if there's a good chance there's a fracture, we will not reduce at all? Those kinds of statements would have to be in there with your supervising MD. Obviously, we know that recurrent dislocations are much easier to relocate or reduce. You've all probably had the patient where they come to you and say, will you put this back in for me? Because it happens so often, they can't do it themselves. They want some help. And it's almost like you put it back in, they're ready to go. And so that's much easier than the person who's a first-time dislocator, who's in a lot of pain, a lot of anxiety, is freaking out, and we have to try and help them through this and manage this situation. Of course, there has to be enough time, and how much time has been taken up since the dislocation occurred. If you're right on the field and you see it and they come over to you within 15 seconds, that's going to be a different scenario than if you're 2 fields away or in a different building and they say, someone just dislocated their kneecap. Can you come over here? And by the time you finish up what you're doing, you get there, it's been 10 or 15 minutes and that joint has been out of place. So that will change the protocol a little bit. Certainly, some joints are very easy. Some joints are more difficult. Some you can do by yourself. Some you're going to need some help with. So maybe you're going to talk about, if alone, we'll do these. If we have partners or a competent assist person, then we can do these. Those kinds of things. And of course, we need to worry about the patient's age and their general health. Where are they at in terms of all that kind of stuff that might help or hurt our on-site reduction process. So what it means is you're going to have to establish a protocol for every single joint that you want to put in your protocol that is an on-site reduction. You may have a list of, we will not do these, all right? So the protocol or the guidelines have to be, global in nature, but we need it for every joint, all right? And we got to make sure, as Dr. Kuzma talked about with the legality, make sure the employer's on board, the regs, the state stuff. We have to take into account your qualifications, your experience. We'll get into some potential challenges when we deal with new certified athletic trainers. But if you are a seasoned veteran and you have lots of experience and parts of your staff do not, we have to make that work, right? So we don't want to force anyone to do anything, but we don't want to paint a picture that sets us up for failure as well. And I think the biggest key to all of this, one of the biggest take-home messages and pearls, is the supervising physician, all right? All of this can be written up by the athletic trainer and their staff, but all of it must be approved and gone over, revised, tweaked, whatever you want to call it, by the supervising MD. And they will probably, in certain parts of it, be able to do more of the writing. However, they may not have the time, so you may have to do it and then revise it for them. But we have to specifically talk about those circumstances, when we can attempt it, who is qualified. Maybe it's not going to be your younger staff. Maybe they need to grow into this. And then certainly, which techniques are we going to use? This is key. You have to be educated, and we'll talk more about that as we move through this. A thing you might want to include, I think it's always a good idea to include it, but I don't know that it's always necessary, is to come up with a bunch of definitions of words that are common to this kind of management. And I look at this as more for the administration. I look at this as more of the system legal. I look at this more for the coaches or the non-healthcare professionals that are involved with this because it's their athletes or it's their department or whatever. And the one that comes to mind that people don't really understand is a spontaneous reduction. A lot of tibiofemoral dislocations occur, and by the time we get to see the athlete and they're in a tremendous amount of pain and we got serious possibilities of neurovascular compromise, is that the joint looks normal. It's spontaneously reduced itself, and yet you go to do anything with that joint, it's like a piece of spaghetti. And so we got a significant injury that doesn't look as bad to the naked eye, but certainly it is going to be treated as a dislocation that has gone in without our assistance and still needs to be treated as such. These are two pretty strong statements that need quite a bit of elaboration. They're two examples of how you want to be very detailed and pretty straightforward when we're talking about the language you use in your protocols. It does clearly state that we must be instructed by our team physician, all right? and provided the techniques and how to do this stuff and trained. There's a training aspect. All right. What we put in the word team physician. Now, this team physician could be a general practitioner, depending on what facility you work for, who you work with. This could be an orthopedic surgeon. It could be a sports medicine fellow, GP. It doesn't matter who your actual team physician is, but someone has to sign off on this. Someone has to be involved in this process. And so if it doesn't happen to be an orthopedic surgeon who's your team doc, then I would hope you and your GP go to the orthopedic surgeon and say, okay, here's our document. This is what we're thinking. Give us specifics. How would you help us write this? And then would you be so kind as to teach us these techniques and sign off on the standing orders related to it? There has to be some kind of collaboration. I'll talk about that in potential challenges. But you need that standing order. You need that verbal confirmation. If the doc is there with you, it's a no-brainer. But if they're not there, we got to have that standing order that allows us to do these things. And I think the more detailed we are, the better off we're going to be. When we get into wording for specific joints, okay, we probably can refer and use our allies that would buff up our case and give us more credibility. If you reference the BOC standards of professional practice, if you reference your State Practice Act, if you reference certain key things in the position statement that give you, and you use language like under the direction of a physician or under the direction of my team physician, we can do this, that, and the other thing. We shouldn't do this, we shouldn't do that. And you start listing these things that you can and cannot do. If we do that, I think we're going to be much better off. I am of the firm belief that the more detail in this kind of protocol or guidelines is going to be much better than something very ambiguous. I think ambiguousness can get us into trouble with other interpretations by other healthcare professionals, by other interpretations of lawyers, by non-healthcare people, our administrators, our AADs, and so on. So the more specific we can get with our language that allows us to do these things, I think that it tells the non-healthcare professionals, boy, they took a lot of time, they took a lot of effort, they looked at all of the possibilities, and they've tried to incorporate all of those. Whether that's multiple attempts are not recommended, or in certain joints, multiple attempts are recommended. All right, but it should be only a second, it should be a third. Those kinds of things you can definitely put in there. So we've talked, Dr. Kuzma will talk a little bit more about some joint management things specifically. I've talked a little bit about the general patient management considerations. Again, those probably are going to be more general in the front of your document, and then you go toward more specific as you get toward the back, or however you want to lay it out. We're not going to talk a ton about special populations. We already alluded to that it's okay to reduce patellofemoral joint dislocations in children. That's an exception to the rule on dislocating reductions in minors. If you look in the document, the position statement, it talks about senior athletes, it talks about diabetic athletes, it talks about those suffering dislocation after seizure, and it does mention children. So in my role in a college setting, I don't have to worry about minors. I don't have to worry about a lot of things. Diabetic athlete might be the biggest one. Just so that you understand that special population considerations may not be something you have to do. It may be appropriate, it may not, but certainly it's something that should be considered as part of your document if you feel the need. So one of the largest things we have to do, I think, as a former head athletic trainer, is to verify that we have met the scrutiny of what we're supposed to do in terms of that training component. All right. We're going to have a doctor in a room teaching us these things, and we must be able to verify 2-3 years from now, next month, whatever the case may be, that we were taught on this date by this doctor for this reduction technique. And here's the date, the location, the signatures. And so in doing that, now it may not be actually part of the protocol say that we're going to verify compliance of all of these rules and guidelines. You have to be able to produce that. And so Dr. Susan Razi at the College of Charleston was nice enough to share this document, one of two that she shared. This is if you're going to do it in aggregate. You're going to do it as a group. So you have 3 or 4 athletic trainers working with you. You're going to bring in your team doc, maybe even 2 docs, and you're going to go through each individual joint that you feel on-site reduction is possible. You're going to learn the techniques. You're going to fill out the form, check the boxes, and you're done as a staff per se. Now, again, this is a template. This is not an all-knowing, all thing. You can modify it. You can change it. You may have your own ideas, but the idea is you have a document. You have the appropriate signatures. You have the dates. You have those who are in attendance. You talk about specific joints talked about that earlier, that you got to have a policy for each specific joint, and we can do this in aggregate. But let's say somebody retires, someone leaves, you hire a new person, and they weren't there for the original training or the first of the year training in aggregate with all the rest of the staff. So now the team doc or the person who's in charge of training you is going to do this one-on-one. So on this page, you can do 2 different joints, and if your doc's going to let you do 6 different joints with specific reduction techniques, you need 3 pages. You're going to have the time, the date, who was involved, and all that kind of stuff. So again, use these as a template. These are not, this is just an example. We all have our own ideas on how to do this, but we have to verify compliance. Your administrators, your system legal is going to want to see these. That proves that you were trained in the event that there's a problem. Now, Dr. Kuzma will take you through some very specifics related to these forms and some reduction techniques.
So when you're looking at trying to document verification of training, one of the things, especially if you're doing it for staff or group, is to go over each joint. So in this example, I'll go over the glenohumeral joint. So one of the things is discussing and teaching the staff what is the typical presentation of the dislocation. A glenohumeral joint, as we talked, can be dislocated anteriorly, it can be dislocated inferiorly, it can be dislocated posteriorly, and each dislocation has a different position. If someone dislocates inferiorly, their hand is usually held up over their head, whereas if it's an anterior dislocation, which is obviously the most common, they're going to be holding usually their forearm internally rotated to their body, holding it close, but their arm is going to be slightly away from their body, as you can see in this picture. Then when they get to the sideline, depending what sport, if it's basketball, it may be very obvious to be able to see that their shoulder is dislocated. In football, having shoulder pads, it may not be as obvious. So this may be something where they get over to the sideline and you have to feel under the shoulder pads to feel if it's dislocated, feel if there's a deformity, if there's prominence of the shoulder anteriorly, or sometimes getting them off the sideline under a tent or anything like that to get the shoulder pads off to then examine the shoulder more closely. Then, once you've determined that they have an anterior shoulder dislocation, we'll be going through the specific techniques. In this scenario, there's a multiple techniques that are described, but for what I would recommend are one of these 3 techniques. If you're an individual by yourself and you get to them very early, you can use the Milch technique. You take their arm and you abduct it and externally rotate it. This picture doesn't show up, but a lot of times having a support, your hand supporting the anterior shoulder and then providing a little gentle posterior directed force as you abduct and externally rotate can reduce the joint, especially if it's before the muscle spasm has set in. If you're indoors, if you have multiple staff, or if it's been a little bit since the dislocation, you can do the traction counter traction, where you have someone wrap a sheet around the patient's body, and then the other person is providing traction and then also performing similar to a Milch maneuver. If you don't have help, or there's someone who's had recurrent dislocations, you can use the Stimson technique, where you have a person lie prone on a table, attach a weight, whether it's an ankle weight or a Velcro weight, to their forearm, and just let them sit with their arm with a little bit of gentle traction with the weight, and a lot of times that will reduce the dislocation on its own. Then, obviously, anytime you perform a reduction, it's very important to stabilize them. Even in the athletes that have had recurrent dislocations and say, I just need to put back in and I'll get back out there, you should really immobilize it. And then it's not urgent if you're able to reduce it, but then they should be sent to a medical facility for follow-up to get x-rays, whether that's like like you mentioned before, whether it's at halftime, whether it's after the game, in a more controlled setting, getting them to a physician to get x-rays is really important, because as this x-ray shows, there's a bony fracture from the dislocation, and that can really determine a lot more of the treatment options and where to go. Then once you've gone through that, this would be the form that you've completed for the staff. You check off that you've discussed and you've gone over the glenohumeral joint. You list the specific techniques taught by the team physician. In my opinion, it's always good to have multiple different techniques, because there's different scenarios that each one is better for. And then you want to you want to note the circumstances when it can be attempted. So you can have the general statement of, according to the general patient management considerations detailed on the policy statement, which kind of would be everything you've developed. Or you can also say other additional circumstances. In this case, from my perspective, if there's a limb-threatening situation where there's a neurovascular compromise, if you get to the patient and they don't have a pulse, performing a reduction, even in situations where you normally wouldn't, might be more beneficial to restore blood flow, especially if you're in a place that's remote from a medical facility where it would take a long time to get there and potentially put their limb at compromise. And then you want to document who did the training, the verifying physician, where it was done, the date, and the location, so that you can save that for the staff. And then I didn't put it on the bottom of this one, but then you want to list the names and the credentials of all people that were trained and that you feel are qualified to be able to perform the reduction. Once you've done that as a staff, if, as we discussed, then someone else is hired later, and you need to do a more one-on-one, the next few examples will go through an individual, for an individual athletic trainer. In this example, looking at an interphalangeal joint dislocation for a finger. These are very common in sports, particularly basketball as well as football. These are the ones that they used to call a coach's finger, a coach's dislocation, because the player would come over and the coach would just reduce it. Now they're coming to us as the physicians or the athletic trainers to be able to perform this. So you want to be able to see when they come off, what position is their finger in? As you see on the left here, this is more of a dorsal dislocation, a very common dislocation, whereas on the right-hand side, this is more of a lateral dislocation, and those come with different considerations on what structures are injured, and then the technique you would want to use to be able to reduce it. You then want to go through the techniques. For a dorsal dislocation, providing just some traction as well as some volar pressure on the distal segment, and then some maybe dorsal pressure on the more proximal segment will likely get it reduced. For a lateral dislocation, such as on the right, providing traction and then more of either a varus or valgus force, we'll be able to get that reduced in place. After it's reduced, you want to see, is the patient able to move their finger? What, is it still appear that it's dislocated? Is there additional deformity? Did you feel any bony crepitance or anything else that will make you concerned for another injury? Then afterwards, just like everything, you want to immobilize the joint and stabilize it after you've performed the reduction. For a finger, you can easily just buddy tape it to the adjacent digit. And again, it's important to get the patient to a medical facility to get follow-up imaging, because as in the picture on the right, even though the joint may look reduced and the swelling from the injury may hide a lot of the residual deformity, they may have a fracture of the articular surface, and not identifying and addressing that can cause a lot of problems and deformities for the patient down the road. Additionally, when you look at a patellofemoral joint, which again is a very common dislocation, you want to think about, how did it happen? What position is the patient in? Is their knee extended and the patella is dislocated? Are they more flexed? Is their knee rotated? Is it truly an isolated patellofemoral dislocation, or is it potentially a tibiofemoral dislocation and the patella just looks dislocated because of malrotation? If you're able to be confident that it's truly just a patellofemoral dislocation, then you can obviously go forward and reduce it. For a patellofemoral dislocation, these are one of the easier joints to reduce as well. Typically providing just some medial pressure with your hand as you extend the knee will allow the joint, the patella, to reduce. Again, this is one you don't want to perform multiple times. If it's not going in, then it's important to get it to a medical facility for further management. And then again, as always, once you've reduced it, you want to stabilize and immobilize the joint with a knee immobilizer or some other form, whatever your facility has, and then get them to a medical facility for further imaging to look for any articular fractures or anything else that may really impact the the post-injury course and treatment considerations. And then once you've done that, then you can go through for the individual athletic trainer to document. So in this case, I used Scott Doberstein that we went through training. We went through the circumstances when the reduction can be attempted, again, according to the general management considerations or any other circumstances you would recommend, and then any of the joints that you went through the training on. So for the joint, going through the interphalangeal joint, and then, I put my team physician name instead of the reduction technique, but you want to document the techniques as we did for this staff. So whether it is, just gentle traction, if there's any specific names or different ones to do, and then the date and the location of where the training occurred, and then the signature of the verifying physician saying you've gone through this and you approve that athletic trainer to be performing these on-site reductions in the future.
All right. We're going to end with some potential challenges. And I wish I could tell you that you were going to have any obstacles in trying to create a document or revise your current document to develop this comprehensive policy and protocols. But there are going to be some things that you have to work through depending on your specific situation. If you work for multiple or you have multiple supervising MDs, someone should be denoted as your team physician, but maybe not. Maybe they're co-team physicians. Maybe you don't have a direct supervisor, but you have multiple supervisors. We all have to be on board. All of them are going to be signing off on this. So there may be an extra layer or two if you're dealing with more than a single physician who's the one who's going to write the standing orders or sign off on this protocol that you're developing. What if, in the rare instance, at least in my experience, there's a physician that doesn't understand what we do, doesn't believe we have the knowledge, the credibility, or the skill set to do this stuff. They don't feel confident in our ability on the field to reduce these dislocations. That is a challenge you're going to have to work through, because ultimately, if they're not going to sign off on anything, then you're going to have your policy and procedures are going to be: we will not do any on-site reductions. We will splint and ship everything. What if you have staff members who are not comfortable with this? Remember, the position statement is a guideline if you so choose to use it. Anyone uncomfortable with doing any of the things we've talked about doesn't have to do it. They are not mandated by your policy or by the position statement to do those things. All right. So there probably needs to be some language in that ATs feeling comfortable may perform the following on-site reductions. ATs uncomfortable should not be forced to do anything. And so we have to make sure that that's kind of clear that we're going to talk about, the newly certified. That is a whole different, it's very related to this uncomfortableness. But you may have a veteran who's never worked with collision sports, and now all of a sudden being told that if you're working across country and someone dislocates something, you're going to have to reduce it. That's not what we are talking about and what we're meaning by any stretch of the imagination. So now we have newly certified athletic trainers. In theory, they've been taught the didactic roles of dislocations and how we reduce and all that kind of stuff. But clinically, they probably haven't seen much. They may have seen a few. They never reduced any. They may have been taught clinically what their certified just did. And they're not going to forget it, but they still are going to have that patient come up to them for the first time at some point and say, I just dislocated this, and you're going to be asked to do something, or maybe not asked, but at least feel like you should. So where are these newly certified athletic trainers in their experience level that's going to be relating to this kind of thing? Of course, we have newly certified athletic trainers compared to seasoned veterans and the skill gap. Those of us that have been around a long time and have seen many of these done with our team docs or us doing them ourselves, have this experience, have this confidence, have this place of knowing what to expect, whereas newly certifieds don't. And if they're on their own and they haven't developed these skills yet, it's going to be more difficult. So that is a potential challenge. And of course, if you have a large staff, it plays into all of this. If I am the head athletic trainer, I only have 2 assistants, and us core 3 are figuring out what we want to do, and we all feel comfortable with it, great. But if we have 13 at a Division I level of a staff, and we got people covering collision sports, and we got people covering non-contact sports, we have seasoned veterans, we have newer athletic trainers, we have multiple physicians, you can see where when you get more cooks in the kitchen, that can actually complicate things. So you're going to have to work through that as you develop these things. And all of that is very important if we're going to benefit our patients. So what I am here and what we're here to tell you is that this is going to take a very collaborative effort. It's going to take a lot of work. If you have not developed a current protocol or guidelines right now based off of the position statement, you're in for a lot of work. It's got to be very collaborative with your administration, with your staff, with your team docs, and so on. And you can consider, you take the lead, and they're going to have to help you through it once you've done most of the work. And if you've already gotten one of these documents up and running and you've been following it, now the position statement is out. Now you've heard this talk. You may have heard other talks related to this kind of stuff. And certainly you're going to need to know what those revisions look like, and is everybody on board with tweaking this or tweaking that? It's going to take a big effort. There's no doubt. This is not, you're going to get it done in a week and it's going to be over and done with. You have the training to take care of. You got the compliance verification forms to take care of. There's a lot of work to be done, and it certainly can be done and delegated out, but someone has to take responsibility and the MD has to sign off on it. And if we accomplish the goal of taking this general roadmap of a position statement and funneling it down to a very specific thing to our needs and our wants at our institution, we're going to be much better as a healthcare profession, and certainly our patients are going to be much better for it. Thank you very much for your time.